Hey everyone, welcome back to the Doc Talk podcast. I'm Dr. Sheila Wijayasinghe, a family doctor in Toronto.
And I'm Dr. Shaz Mamathani, an ER doctor in Edmonton.
So we're continuing with our Pitt recap episodes with a specific focus today on episodes 6 and 7, two really intense hours that dig into the realities of abortion care, privatization in medicine, and how the system pushes people, patients, and clinicians right to the edge.
Yeah, and these ones felt especially raw. There was a mixture of moral distress, burnout, and these moments where you just see how human everybody in the ER really is.
And we're going to do a couple more of those teaching corners on a couple of key cases that will be helpful if you are ever in a situation that we saw on the screen, or if you're a med student or a healthcare provider. These will hopefully be helpful as learning points as well.
And that's a specific shout out to my friend, Jake. Hopefully it's okay that I'm mentioning your name. He is a med student, and he has told me how helpful these episodes have been for him and how helpful the Pitt has actually been for learning as a medical student because of just how real it is.
I remember that, how ER was a very big learning piece for me as a medical student in residence. And so I'm so excited that our current learners get the Pitt as their opportunity for learning because it's so accurate.
Love it.
So for those of you who are joining us for the first time, every episode of The Pitt is an hour of a shift. And this episode number 6, is the 12 p.m. to 1 p.m. time slot of a shift. And so this episode starts off right where we left off in episode 5 of a teen pregnancy and the abortion storyline, where Christy's mom from the last episode turns out just to be her aunt, and the real mom storms in.
So this scene captured so much of what we see in the ER, and that's family conflict. There are so many situations where families will come in kind of partway through care and then create this tension that is really palpable. This scene in particular is a mix of conflict, fear, and moral tension, all kind of under the emergency department lights. Now in the Emerge, we've seen this kind of displayed in the show as well. Every room is pretty much separated by curtains, save for a few. And so oftentimes, many of the other patients surrounding these patients can hear what's going on or hear, yells, screams, whatever the case may be. In this situation, Robbie gives them the space to talk before making decisions. And I often do that too when things get heated up. I, try to de-escalate the situation, step out, remove a family member that might be increasing the tension or escalating things, and give people a moment to talk and de-escalate themselves, and also kind of do my best to de-escalate the situation all around us.
I mean, there's so many emotions in the emergency room, Shaz, and you are directly involved in that kind of care. I can only imagine the escalation of sadness, anger, fear, frustration that all happens all at once for these families. And so it's a really good tool, is that de-escalation that you do.
Yeah. And I will say that that is a tool that it's so valuable in the ER, but I now use it in the rest of my everyday life a lot with my kids, actually.
Oh, yes.
Even with my husband, with friends, or in, other situations, advocacy situations, whatever the case may be, in meetings, other forms of conflict. I use the skills that I've gained in the ER to apply to the rest of my everyday life, especially when it comes to conflict, because it's something that I deal with so much in the ER.
So we're going to jump right into our first teaching corner based on this case, because we found it really impactful and very true to what we see every day. And so we go back to this teen pregnancy situation where the aunt and the mom are fighting over what should happen. And you can feel how uncomfortable everybody is in the room, including all the healthcare providers and the people who are listening in on the conversation as well. Like you said, Shaz, people are listening, right? And Dr. Collins is trying to advocate for the teenager, but you can see that she's also struggling because she's dealing with her own pregnancy at the same time.
Yeah, this is really one of the most realistic storylines that I've seen so far in the show. You can really see that tension between respecting the autonomy and managing family conflict. And the line that really hit me was when Collins said, "A woman should only have a child if she wants to."
And so that scene really opens up an important conversation around consent and capacity, especially when it comes to young people making reproductive choices.
Yeah, and this is where we're going to get into the bulk of this teaching corner, because I think it's important to understand what that means in Canada in particular. And so many people don't know that in Canada, there isn't actually a fixed age where someone can consent to medical care. What actually matters is capacity, which is whether the person understands what is happening, the risks, and the consequences of their decision. Now, if a young person shows that they have understanding, they can make their own medical decisions, including for reproductive care. Some provinces have specific guidelines, in particular New Brunswick, where 16 is the default, and Quebec, where youth can consent at the age of 14. But most of the country follows what's called the mature minor doctrine, which means that once the capacity is assessed on an individual situation, it's assessed case by case. So you may have the capacity for one situation, but not have capacity for another. if it's deemed that the patient has capacity, no matter what their age is, within reason, that autonomy is respected and the person is capable of making that informed consent for that situation.
And this is something I see often in family medicine as well, because I have a lot of teenagers in my practice that I've followed since they were kids, and I actually found like I follow their whole families actually, so the entire family sees me as their family doctor. And the teenager may come in on their own, specifically for contraception or abortion care, and if they clearly understand what they're asking for, and I review the risks, benefits of anything that we're talking about, and they can consent to that, it's my responsibility to respect that. But it's never black and white because, there are so many emotions and family dynamics and cultural expectations layered upon that. But I always look at my patient who's in front of me and I give them reassurance that this is your private space. This is not something that I'm sharing with everybody in your family. And we have a fulsome discussion so that they can make the decision that's right for them. And if they have that capacity, like you said, Shaz, then we go forward with that decision.
Yeah. And in the ER, we very much see the acute end of that. I will often, if I'm coming in to see a teen, I'll ask parents to leave, or I'll ask the teen in front of the parent, do you want this parent to stay or do you want them to go? And give them that space, reassure them that any conversations we have are confidential. And, oftentimes when families are in crisis, there are times where decisions need to be made fast. So you can see why Collins kind of hesitated. She's trying to do the right thing here in this case, trying to do right by her patient, but she's also trying to keep the peace. It's like this constant struggle and tension that we can often have. And it's a good reminder that autonomy doesn't exist in a vacuum. We still have to navigate the human side of it too.
Yeah, and I think the show handled that nuance really well. So it wasn't about being right or wrong. It was showing how complex these moments are for both patients and for clinicians.
So next we kind of see this hallway interaction that happens, right? With the chief of the hospital, there's another person that kind of comes into play, and we kind of see where capitalism meets care in the US setting. And so what I love about the way the Pitt structured this episode is that it jumps from kind of one moral complexity with the case that we just talked about with abortion care into another one where Robbie we see him go toe to toe with that private care executive.
Right. And this is when he calls her out for putting profit over our patients.
Yeah, that line in particular, your contract management's corporate mandate is for profits for shareholders above everything else. No. So he kind of asked us this rhetorical question, and she is this smooth corporate talker that has an answer for everything.
MBA,
yes,
business
absolutely.
and medicine.
Yeah, and she navigated that conversation in a very kind of, political, strategic way. And I mean, it was giving me this feeling in my chest. I was getting countertransference from the situation because you could have ripped that straight out of real life. It's something that we've started to see creep into Canada with more kind of for-profit surgical centers, diagnostics, and even virtual care platforms.
Yeah, and it's such an important point. And Shaz, you actually deep dived into this a little bit further on another podcast called Money Feels earlier this year. I think it was episode 80. And, you broke down what privatization means in Canada. And I think that's such an important lesson for those who are listening to us now, because we also are at risk in Canada of this private infusing the public system.
Yeah, so that conversation I had with the hosts, Alyssa and Bridget, was all about how more choice or efficiency can sound good on paper, but it's usually just a way to let people with money skip the line without actually fixing wait times for anyone else in the public system. And so in that episode, we talked about how profit-driven care shifts focus from patients to shareholders and why a stronger public system benefits everybody. So please check out that episode of Money Feels, episode 80.
Yeah, it ties in perfectly here because what we keep on seeing on the Pitt is that episode after episode, we know how fragile the system is, especially when we start valuing profit over people. So next up, we're going to go a little bit into some of the humor and the chaos of the emergency room, which I always appreciate because I need a breathing space sometimes on this show because it's so heavy.
They do a good job of that.
They do a good job of balancing things. So episode 6 really leans into the procedural chaos of things. There's multiple traumas that land back to back, one with a chest injury, another from a stolen ambulance crash. And this is all at once happening in the chaos of the emergency room.
And Santos finally gets that chest tube that she's been chasing all shift long. So it's a messy, loud, and totally real situation. And we see that while she's cutting into the skin, I mean, everything they prepped was perfect. It is medically accurate, but as she's cutting through the skin, she fumbles her scalpel and it lands in Garcia's foot. And you hear that quote from Dr. Robbie, the camera pans to him and he's just oh, that's gotta hurt. And it was just this moment of we see Santos finally getting the procedure that she wants. There's this growing interaction between Santos and Garcia, maybe a flirtation. I'm not really sure what it is, but it's this building tension. There's clearly some sort of a connection between them and she's being favored by Garcia. And then it all kind of culminates into this moment.
Yeah, that was a moment because I think we're also watching Santos sort of like she's kind of cocky and
Yeah.
and overconfident in a lot of situations, and that was like a very good like level setting her a bit more too.
hmm So I want to just like the little rapid fire segment on like some real, just little, real tidbits of ER realism here. So here's some quick hits for our fellow med nerds. Now, there was this trauma that came in that had a posterior clavicle dislocation. So that is when your collarbone actually pushes backwards, and you could hear that there was like an airway issue. The patient had stridor, was having difficulty breathing. This is super rare and is a true airway emergency. I've never seen one in real life because that is how rare it is, but it is like textbook for what we would see in these situations.
And then there was the Captain Morgan technique for hip dislocation, and dislocated joints are like one of those things for me, Shaz, that I kind of squirm a bit because the sound that you get, like the sound that they made, that was a real sound. Like that was what it sounds like, right? Like
Yeah.
the foot of the bed, you're leveraging it.
And
It's,
that pop.
Javadi's there and the pop that you get. Oh, it was like,
And
oh,
she didn't faint. She didn't faint
she
in
didn't
this one.
faint.
And that Captain Morgan technique, like, yes, that is a real name. Like there was like also this like awkward moment because we know that she's quite young, obviously doesn't drink because she's underage. And like everyone's looking at her like, you don't know what Captain Morgan is. But like anyone who knows what Captain Morgan is, he like literally has his foot up on a barrel. And like that is actually what we call that hip reduction or that hip kind of fixing reduction procedure. And it actually works really, really well.
Have you've relocated hips before?
I've relocated a lot of hips, and that is my my method of choice in terms of how I relocate hips
Captain
now. Because
Morgan.
Captain Morgan, because like before what we used to do is we actually used to like get up onto the bed, straddle the patient. You'd have to have like people spotting you because you're up on a stretcher and you like pull up. And so like you have to really put your back into it. You're at risk of falling, you're at risk of hurting your back. And so like this one is so effective and so much safer for everybody. So it's like definitely my go-to method.
And it's done with sedation.
Yes, it is done with sedation.
Because you have to almost like relax that hip a bit to get it back in, right?
Yeah, exactly.
Amazing.
And then the other one for medical realism is that time is testicle. So Colin's kind of diagnosing torsion, really illustrating
testicular torsion. Yeah.
Yes, testicular torsion. Thank you. And really kind of illustrating how time sensitive it is. She portrayed the urgency really accurately. The bedside ultrasound, though, like not really typical at a tertiary site. We have access to ultrasound, and that is like a reason that ultrasound techs would be called in overnight to diagnose this.
Okay, so I love this because these are the kind of snippets of realism that make the Pitt feel so authentic without turning it into like a tutorial about what to expect in the emergency room. It's really well done. So we want to dive in and do another teaching corner on what you just mentioned, Shaz, on the testicular torsion case, because I think that's actually a really important learning point for patients, but also for any healthcare workers who are listening in.
Yeah. And so testicular torsion is that kind of like that line, time is testicle, is very, very accurate. It's not just like the drama of TV. Testicular torsion is a true emergency. It happens when the spermatic cord twists upon itself and it actually cuts off blood flow to the testicle. And we know that blood is needed to keep things alive because that's what delivers oxygen to an organ. And so the time window to save that testicle is short. And of course, testicles are important for fertility, right? So this can have long-term impacts on a male's fertility, which is why it's such a time-sensitive emergency. Ideally, within 6 hours of the pain starting is when we'd like to get that patient to the operating room, untwist it, because that's after 6 hours is when that salvage rate drops really quickly.
And it can look like a lot of other things too, right? Like, so it could look like epididymitis, which is an infection, or hernia pain. So if you're having pain in this area, it's important to get checked very quickly.
So if you notice not only just pain, but swelling, a change in color, kind of rapid onset, those are all signs of testicular torsion and mean that you should get assessed right away. And so the key takeaway is that, like, if you have any of those things, please see a doctor right away, especially for teens or young adults, because that is kind of a more common age group where we see torsion and a high fertility time, right? And so those patients need to go to the ER immediately because, like we said, time is testicle. They need imaging right away, and they need to see urology right away as well.
Absolutely. And I loved that the show included, I remember this actually, the opening the book reference. So that's the correct like manual detorsion technique, the outward rotation, like opening a book. But I'm assuming that you actually generally just go to surgery at this case, in this situation.
Yeah. So like in a tertiary care hospital where we have urology, which is where I work, like this is something that the urologist would like come in for overnight and get them to the operating room right away. Now, if you're in a rural center where it's like where transport time is going to be an issue, where, you know, you're kind of worried about that 6-hour window, that is something, again, in consultation with urology, kind of in, you know, in the city, so to speak, that would be something where a urologist may talk you through doing the opening the book technique to try to detort it, because there is not enough time to get that patient into a tertiary care center and into the operating room.
Yeah, when I used to work rurally up north, we would have to actually do this when we had the urologist on the phone with us, and they would talk us through the technique, actually. So it is one of those things. The benefit of the tertiary care centers is that you have that immediate surgical support.
For sure.
So Chaz, the next part I wanted to talk about was around that opioid overdose storyline with Nick and his parents. And at this point, we know the perfusion scan that was done confirms brain death. And this was such a beautiful moment where Dr. Robbie, his calm compassion, his patience and gentleness in this moment was so beautiful, but it was also so devastating to watch this moment.
I felt that, like, I mean, just that you could see, again, we've talked about this so many times, Noah Wiley's ability to act non-verbally is just outstanding when it comes to this role. But then you see, I mean, like, you see this immediate contrast from loss to light, because as soon as he walks out of that room with Nick's parents, he runs into Ginger in the hallway, you know, that woman, older woman who has schizophrenia, whose daughter is missing. And she stops him and reminds him that that he had promised her a dance. And so he goes, switches it on for her, and goes and has like this lovely light moment with her. And it really illustrates that ER whiplash that we've talked about before, where we move from grief to levity, often within minutes.
Yeah, that's something that we often have to deal with in medicine, isn't it, Shaz? Like when, for you, moving from room to room in the emergency room, for me also as a family doctor, we close one door, we go into the other, and it's like I take a deep breath and you go. And you may have been giving somebody bad news in one room, as Dr. Robbie was doing, and in the other room, you're sharing a celebratory moment for patients who they're celebrating something beautiful in their lives, and you just kind of go. It can be a bit of a roller coaster, which is, those days are really one of the ones that I have to kind of debrief and take a big moment for myself at the end of those days.
Yeah. And I think on those shifts in particular, like where there's a lot of heavy, I look forward to those little moments of light to get me through. But important to have the time and space to decompress and debrief with who you need to afterwards as well, because we have this tendency as healthcare workers, I think, to just continue to push down the bad and try to work through it. But we know very well that is what ends up getting us into trouble down the road.
Yeah, the Canadian Medical Association just came out with some discussions around mental health in healthcare workers and how significant the impact is post-pandemic, that there's significant depression, anxiety. And so there are resources that we'll include in the show notes for healthcare workers as well to look for support. And we all need that support now and then. So we're going to switch over to episode 7 now, because we're doing a double here. And episode 7 is the time frame of 1 p.m. to 2 p.m. of the shift. And it opens up with a patient who is neurodivergent. And it really displays the importance of communication with these patients.
And we can see that Langdon, he walks into that room and he's clearly struggling to connect with the patient and is not communicating in an effective way. And this is where one of my favorite characters.
Oh, yes. Same.
Dr. King, she shines. So she walks into the room. She immediately recognizes the situation because she looked at the chart, saw that he was autistic, and asked Langdon if she could give it a try. And so she walks into the room, dims the lights, speaks to him calmly, lowers her voice, uses that ankle model to kind of explain everything because she realizes that that's what he needs to understand what's going on. And that's really such a great illustration of trauma-informed care done right.
It was so beautiful. And I think later on, Dr. Collins even emphasizes it to Mel King and says, like, listen to your patient. And like, that's your superpower. And I think that's such a beautiful truth to every patient that we see in medicine. We'll need a different form of communication sometimes, which is sort of the art of medicine, is being able to navigate like what will work for one patient may not work for another. And we have to adjust to make sure that what we're saying is getting through. And so that really is therapeutic in itself.
Yeah. And I think this is a good place to just have a little aside. I mean, emergency departments in particular are really challenging for neurodiverse patients because
Mm.
often these patients are very sensitive to loud sounds and lights. And like, it is really challenging for us in the ER to make it like to adapt our environment, to be able to have a room that has a door, to be able to have a room where we can dim the lights. But we try, when we recognize that this happens, we do our best to shuffle patients around in the best way that we can to put them into one of the few closed door rooms that we have, or try to, get them out as quickly as possible as well.
That's really nice to hear.
Mm-hmm.
We also start to see some of the interesting pieces, and this was really impactful to me as a teacher of medical students and residents, that we start to see the relationships and the fragmentation a little bit of the, not so much respect, but seeing the shine wear down a little bit on some of our teachers and mentors. And we see that Santos starts to see cracks in Langdon's character in terms of his arrogance and some of his shortcuts that he's taking. And that was really interesting to observe.
Yeah. And I mean, like, you can see this like slow loss of faith in mentors and, senior residents, which is a very real thing in medicine. Sometimes we can learn as much bad habits as we do good habits from role models as well. And we certainly see that perpetuated in a lot of situations in the culture of medicine. And so I think that highlights this very well.
Okay, so we had this heart-stopping moment, literally, where there is this large cardiac arrest that comes in and another VFib situation, another charge in an ACLS sequence. Can you tell us a little bit more about this, Shaz? And like, is this what happens in real life?
Yeah. So this is someone who had a STEMI, so a heart attack, right? They kind of roll in. It's as a quote unquote code STEMI. And you can see you can see Whitaker starting to panic in this situation, right? Because he lost his other patient earlier on in the season from what was presumed to be a heart attack. And so he sees this person that he rolls in and they have a cardiac arrest right away. And so the ACLS algorithm, so the advanced cardiac life support algorithm, is done really well in this situation. So they address the rhythm, they look at it, they give medications as they need, and they do defibrillation. And then what they end up starting to realize is that defibrillation is not working. And he continues to be in persistent ventricular fibrillation, which is a rhythm where your heart's not pumping, but it is one where you can deliver a shock. And so they kind of start going down the list of the algorithms of, farther down when the first things aren't working, which is the dual defibrillation, where you have like two defibrillators that you're trying to shock at the same time. That is absolutely something that we do in medicine, and something that I have done myself as well. There is some reasonable evidence. Yes. It's like this thing that maybe like sounds...
Yeah, totally. I was like,
really,
is this real?
like,
I was waiting for this
there.
episode to be able to be like, is this real?
Is this real?
Okay.
And yes, it is absolutely real, and something that we're using more and more in what we would say refractory ventricular fibrillation, where like the usual care is not working. You need the theory is that you're trying to deliver a little bit more energy to the heart to reset it. And then we have the ECMO team come in. And so ECMO is essentially like a heart and lung bypass machine, where if you think that there is something that is reversible for your patient that just needs a little bit more time, that's causing their heart or lungs to not work, that's when you can put them on this bypass machine. And so we see that happen here. Robbie kind of, is coaching Whitaker through it, coaching him through the compressions. And then when they run out of options and that dual defibrillation doesn't work and the ongoing ACLS care doesn't work, they call on the ECMO team to get this patient onto ECMO.
And what's ECMO?
So it stands for extracorporeal membrane oxygenation, which is a fancy way to say the blood is taken outside of the body and it's oxygenated outside of the body and then brought back in.
Yeah, that was such a scene. And it really highlighted to me why I'm not an emergency room doctor. Like, I remember being a learner like Whitaker, and I feel like my classmates who have gone into emergency medicine or surgery like ran to those codes, and I would like slowly.
You like ran in the other
I'm like,
direction.
this is not my, like, I will hold my patient's hand and support them and do preventative care for those heart attacks, but in that moment, like, it's really overwhelming. So I can, Whitaker's face and like seeing that, I really appreciated how gentle Robbie is with the team and with his learners, because that's what you need to get comfortable with these situations that are really overwhelming. But yes, it was very much a highlighting moment for me of like, this is why I don't do emergency medicine.
And for the record, for the listeners, which should be no surprise, I was the one running towards the cardiac
I imagine.
arrest.
Yes. Yes. You're also the one that's probably putting bets on the ambulance too.
Absolutely. Yes.
Yeah. So, the episode 7 ends with quite a big moment, and it was very upsetting to watch this as well, where the episode ends with Dr. Collins miscarriaging. after managing the pregnancy termination case. And it was such a gut punch to see this because it was such a raw portrayal of what it costs to care and that we are humans too as healthcare providers. And we experience the same things that our patients experience.
Mm-hmm. And I think that this scene just did such a good job of illustrating that. We see that blurred line between what is personal, what we carry into work, what can happen at work to us sometimes, and that professional line, that fine line that every healthcare worker has to walk every day.
And so again, we're going to put them in the resource notes on the episode notes, but there are resources that we'll share around professional health supports for healthcare providers as well. Okay, before we wrap up, can we just take a second for a little behind the scenes fun facts about the Pitt?
Okay, yeah, I love this. What do you got, Sheila?
So apparently on the set, they had a book library, like an actual set of books. And they actually encourage people not to have their phones on set. And instead of being on their phones, they suggested to read and chat about what they're reading instead of being on their actual telephones.
Wow. Okay. That's news to me. I love that. And it's actually it feels really fitting for the show because it feels like kind of like deliberate grounding and intention in the context of the chaos of an emergency department. So I love that they're bringing that onto the set.
Yeah. And it create this focus energy to the set, right? Like there's so much energy, like you said, the chaos, but then having a grounding spot for everybody. They really, like the directors and Noah Wiley, really wanted the environment to feel like a real hospital. So no distractions, just total immersion.
Yeah. And I love that. And, there's like other aspects that I've like just learned on Instagram and on social media about different kind of behind the scenes thing. And so it sounds like I learned recently that they also went into deep training with the cast as well. So every doctor who played a doctor or a nurse, they actually had to learn the real procedures. So like they had to learn how to intubate. They had to learn how to put IVs in as nurses. They had to learn how to like click and use the monitors. So everything that you see on screen, like these actors have learned how to do them from real healthcare workers so that it looks and is portrayed so accurately. And I get that. I see that because even just like the manual, like the way they hold things, the way like when they're holding a laryngoscope or a gyroscope, like those things all look as they would in real life in the Emerge. And now I understand why that is the case.
Yeah, it always would drive me nuts whenever I'd be watching a medical drama or medical comedy. And I'd be like, the stethoscope is a wrong way. Like they are not hearing anything if the stethoscope is placed on the ears the wrong way.
Or the IV is like taped onto the skin.
Right? Like it's not actually in. So this is where like it goes back to the authenticity of the show. Everything the way that they do everything is so amazing. And that's why the codes look real. It just brought more deep respect to the show and how they really focused on making it so real for the audience, but also for us as healthcare workers. It is like on point.
I love it. And I think it's exactly why it's such a good show. It's not just about the drama. It really is like a nod and shows respect to healthcare workers and the work that these real healthcare workers are doing every day. So let's wrap up this episode with our usual kind of important moments of the week. And let's start with our line of the week. Sheila, what was that for you?
So the one that stood out for me the most was from Dana, who's one of our favorite characters, Shaz, our charge nurse. And she said, you don't have to have all the answers. Sometimes just asking how someone's doing is enough. And I think that's such a true statement because in medicine, we don't always have the answers. We can't always fix everything, but we can always check in on how someone's doing.
I love that one. That resonated so much for me. And I think it's just important for the people who are in healthcare, but also not in healthcare to understand that too.
Mm-hmm. Okay, Shaz, tell me who your MVPs were this week.
So the first MVP that stands out is kind of who we just talked about, and that's Collins. So for her kind of advocating fiercely for this patient to provide abortion care to this teen while also carrying her own private pain that we see kind of unravel at the end of this episode. Mm-hmm. What about for you?
I think it was Whitaker again, for surviving another code after experiencing a death of a patient after doing, life support measures. And then, of course, another scrub change.
I think that's 5.
Maybe 4
5 or 6.
Yeah.
It's a lot. It's a
lot. What was your medical gold star for accuracy, Shaz?
So for me, it was that cardiac arrest. So the portrayal of like the accurate algorithm of ACLS care, followed by the dual sequential defibrillation, followed by the ECMO prep. Like that is exactly the order of events and how things occur. And so that was great for me. What about you?
I thought that the chest tube sequence, like that, again, that's a procedure I remember very clearly, despite it's not something I do anymore, but that was really interesting to watch and it felt very accurate and authentic. And when she dropped it into the foot, that was just a little moment there of levity.
Yeah, that one really stands out. And then also like the bit of the, we didn't really talk about this, but that like badass move of Garcia.
Oh my gosh, sewing herself up, like just ordering Santos around, like, get this needle, get this lidocaine, get this procedure tray for me. Like that was a badass moment for sure. I love that. That was great. Mm-hmm. That was good too. So the key take-home messages from these 2 episodes of The Pitt are that autonomy and reproductive care is non-negotiable. Listen first, even when it's noisy, especially when it's noisy. And the ER's chaos hides small acts of grace that keep us human as healthcare providers.
And for our healthcare workers out there that are listening, here are a few take-homes for you as well. If you're a teacher, remember that students really take in everything you share, down to even the nonverbal things that you're doing and how you treat patients, how you interact with those around you, and how you treat them as well. It lasts their lifetime, so try to encourage them over admonish. Always rule out medical things before stating something is psychiatric. That is really a golden rule in medicine. We are always quick to jump to an anchor to psychiatric doses often, and there can be medical diagnoses that are underlying this as well. And lastly, with Dana's line, we can't always fix the situation, but listening is also therapeutic and often even more impactful.
There's so much rich learning in each Pitt episode that we wanted to create a little corner for our medical learners as well about the things that we've learned that we think are really important for you in your medical training experience.
Here are the top 3 take-home points for medical learners from Pitt episodes 6 and 7. Number 1, capacity is more important than age. So in Canada, there's actually not an age of consent. It really depends more on whether an individual has the capacity to make a decision in that moment.
Number 2, listen before you label. Make sure that if someone's presenting with confusion or delirium, don't assume that it's just psych. Keep your differential wide.
And number 3, compassion is a skill. We don't always have the answer, and we don't always need the answer. Sometimes listening goes a lot farther than you think.
So these 2 episodes cover a lot. The moral gray zones, the constant pressure to move faster, and the cost that comes with caring so deeply in this work.
And what stood out for me was just how much they nailed the emotional fatigue of the job. There's no really tidy resolution in any of the cases, but that's what makes it feel so real.
And so next time we'll be looking at episodes 8 and 9. And if you've been following along, things are about to get even heavier for Santos and Dr. Robbie.
We'll see you then.
A reminder that the Doc Talk podcast is for general information purposes only. This podcast is not intended to replace medical advice from your doctor. While we are doctors, we are not your doctor. Always speak to your own healthcare provider for questions related to your personal health needs. Please be sure to follow us on social media at the Doc Talk Pod and send us your questions.